Thank you, Chris, for that fascinating talk. It's more than I ever thought I needed to know about telecommunications, but apparently it's all important. One thing about being the last session is we don't have to worry about making other people wait. But with that, I'd just like to introduce our last speaker of the day. He is the 36th Surgeon General of the United States Navy, and for those of you who don't know, the Surgeon General that most of us know is a civilian position nominated by the President of the United States. Each service has a Surgeon General, which is the highest ranking officer in that service. Vice Admiral Robinson has been in the Navy for 34 years. He just retired 3 months ago, sir? 3 months ago, after 34 years of dedicated service and, again, achieving the highest rank in the medical profession in the Navy. So without further ado, Vice Admiral Robinson.
Good afternoon. It's nice to be here, and it's also nice to be the last speaker on the last day, in the last hour, in the last session, in the last auditorium open for SAGES. I want to thank everyone before me. This has been very fascinating. I have learned a tremendous amount. I particularly want to tell Colonel Rush I really appreciated what you were talking about, and I liked the fact that you talked not in terms of just Army, but also of the military health system, which is what I'm going to talk about today also. A couple of things before we get started, and I'll be quick. And I'm going to truncate some of my presentation, so I think I'm going to leave this at probably 10 to 12 minutes. And forgive me if I hit slides and ask to go forward, but that's how we're going to try to do this. And somebody's going to have to show me how to hit the slides. So, got it. So one of the things I want to say, first of all, is SAGES is an organization I have belonged to since about 1978 or 79, and for those of you who keep the historical data on SAGES, that was really at the very beginning. But I remember this meeting being at the National Naval Medical Center in the Officers Club, in which there were probably about 35 or 40 people that attended. And then I remember this meeting also being in San Diego probably 20 years ago, 25 years ago, in which the auditorium that was used was probably twice as big as was needed. And then we come back to this year, in which we're at the second largest surgical meeting in the world, which is an amazing thing. So SAGES has really come of age. The second thing, very quickly, is the military section on SAGES is, from my point of view, absolutely critical, and Colonel Lim and Colonel Rush and all the members of that committee, I commend you and ask you to continue. Commander Westbach, I want you to continue to work, because it's important that military medicine stay engaged. I think some of the things that we're talking about with telemedicine, telementoring, it may not seem that there is a necessity on the civilian side, and I appreciate what you said, but I can tell you two things that I will predict today. It is an absolute necessity on the military side. It is a necessity on humanitarian assistance and disaster relief side. And it is also something that seems far-fetched in 2012, but will not be far-fetched very much longer, because I predict in the next 20 to 25 years it will be the standard of care for many situations, the telementoring, the telerobotic, a lot of the things that we're doing. Now I'm going to get to the talk, and we're going to see if we can go forward. My talk is heavy Navy. That's because I was a Navy Surgeon General. So I'm going to try to hit those areas, but I want to make sure that everyone recognizes that I'm talking about the military health system, and I'll try to emphasize that as I go along. The Navy has been involved in many facets of maritime security and also humanitarian assistance and disaster relief, those two redded bullets that you have there. This is something that is exceptionally important and something that we have been doing a lot of for many years. Very quickly, Navy medicine, approximately $6 billion global health care network, 63,000 people, expeditionary medical care, cornerstone of soft power, as our nation calls it, and medical diplomacy worldwide. Each of our services, the Air Force and the Army, and remember the Navy takes care of the Marine Corps, does an equal job. The Army is the largest of the medical institutions in the armed forces. The Air Force is the smallest. The Navy is the middle. But we're all in this together, and this is what we do. In terms of Navy medicine, I love the fact that Colonel Rush indicated that we do our day jobs and then we go off and do our other jobs. Our day jobs are that TRICARE network, that expeditionary medical care that means that we take care of those eligible family members And that is what we have to do. But I want to make sure that you go over to the operational fleet and the fleet maritime and the readiness. And by the way, operational fleet maritime, that can be Army or Air Force in the sense of what their operational missions are. Because the military health system, its whole purpose to be is not to do garrison health care. Its purpose is to do war surgery and to support the war fighter. And that's the reason that we exist. But in order to stay ready to do that, you also have to make sure that you have a very codified and meaningful system of training and experience, and that's where garrison care and that's where eligible family member care comes into place. Because what do you do when the war is over? In terms of the philosophy of what we do, I want to make sure that we understand that the triad you see here is a triad that has as its very core patient and family-centered care. So you have such things as research and development, you have health services and wellness, you have the full readiness of the military personnel force. Those are the three parts of the triangle. But at the center, you have that core, which is patient and family-centered care, which is the concept of care that makes it important and in fact, gives us the ability to care for those people that we're after. Navy medicine deploys with the Marine Corps. Marine medicine is actually Navy medicine. The Marines do not go anywhere without corpsmen, nurses, physicians, and allied health specialists. We're there, we're supporting them in every major operation in which they're involved in. Historically, the trauma system that or the trauma care that we develop during our conflicts ends up producing a lot of innovation and newness in terms of how we care for patients in the civilian health care. I suggest to you that telementoring, telemedicine, and some of the other very new, actually some of them are not so new, but the new approaches we're taking are going to continue to enhance what we're going to do in the civilian healthcare system as the years progress, because there's going to be a great deal of synergy and a great deal of leverage of making sure that we can go into remote areas, underserved areas with underserved personnel, and be able to send in medical providers, not necessarily always physicians, but medical providers who will be guided in what they do from physicians or other medical experts that will be able to help them vis-a-vis telemedicine, teleradiology, telepsychiatry, teledermatology, all of those aspects that are going to be very important. And we in the armed forces have leveraged the use of this technology because very often we have patients in situations in which we don't have providers, and in fact we need to make sure that we can in fact get credible care. I'm truncating that slide, but I'll continue to go. Caring for our warriors today is the utmost responsibility that we have. I think that the Army, Navy, Air Force have done an incredible job at having a very good system of caring, and I think that that system has improved through the years and that we will leverage as we go forward. The continuum of care is from level 1 to level 5. You know, those of you who have been in the military understand the different levels of care. The reason that I place this slide here is that it's so important to recognize that the levels of care from our primary providers, our corpsmen, and actually the buddy care that occurs in the battlefield, all the way to the rehabilitative and restorative care at the level 5, that there is a continuum here, and the emphasis I want to make in this instance is one thing: the en-route care, which has been championed mainly by the Air Force, but certainly with Army and Navy help, to allow patients who are critically and drastically injured to be transferred long distances. And as some trauma surgeons have said when I have been in Kandahar and also in Iraq, you take patients via a C-17 Elange that we wouldn't put on an elevator and take one flight to the OR. So it's a very impressive continuum of care, and one that we should be proud of in the military, and one that has absolutely translational results in the civilian side. Combat stress and mental health. This is a major issue for the military. I think all of us know that. It's something that we really must become involved in. One of the reasons that I'm going to talk about this slide just for a moment isn't to talk about suicide prevention, PTS, traumatic brain injury, those are topics that you can read about, and there's a lot of information about that. It is to emphasize the fact that two things have to be done. We have to take care of the individuals that are involved in the war. We have to take care of their families, and that the care that they must receive is not care that will be a one-time or a one-shot deal. It is care that will have to be provided with PTS, with traumatic brain, with family care. It will have to be provided over a continuum, just as the amputation and the prosthesis care will have to be provided over the life of those young men and women, our warriors who are wounded. That means that this century, this 21st century, is going to challenge Americans and all other host nations that have people in the war to make sure that they care for those wounded warriors in the years to come. Traumatic brain injury, I'm not going to talk about this. I'm not going to talk about the Navy's medical priorities, other than to say that telementoring, telemedicine, and simulation are major priorities for all services, and we must make sure that we, in fact, invest in them both from a monetary and also a human resource perspective. There are lots of things that I can talk about with predictive biomarkers of wound healing, heterotopic bone, the critical capabilities and interventional research. This slide indicates that we have to make sure that we measure, that we do codified and credible collection of data, that data is collected at the level 1 and the level 2, the lowest levels, which are often overlooked, that we look at that data and that we actually do some analytics and develop measures so that we can understand if we're progressing or if we're not. This is going to be increasingly important to make sure that we can prove that what we're doing is not only the right thing, but is also helping our patients. Translational research, which is the end result of a lot of what we do, is what I often talk about. The products that we're delivering are there. Most of you who've been at ATAC and other different meetings in the military know that there are a host of products that we're developing. R&D is a major emphasis of the Army, a major emphasis of the Navy, and also of the Air Force to make sure that we do the right things, that we get the products that our men and our medics and corpsmen need in the field. Products in the pipeline are very interesting. They're very good. I'm not going to spend any time talking about them other than to say that I think that the telemedicine and what is occurring with this particular session and this meeting is incredibly important. And I think that of all of the products in our pipeline, this is one that would be probably, my opinion, one of the most critical because it involves the type of intellectual advantage and the type of ability to provide long-range, credible support to underserved areas and areas that do not have the expertise in surgery or whatever we're talking about. I think that telemedicine and telementoring are ways that we can overcome that. With that, it has been my distinct honor. Thank you very much, Rob, for inviting me. It's been my distinct honor to be with you today, and thank you very much.
Before we take any questions, I just want to make one comment. I wanted to thank my fellow panel members today for all their hard work. To Dr. Shalon, Dr. Nguyen, I know this is kind of a heavy military session, but I think your contributions, I think it's pretty easy for people to see that you guys see the bigger picture in all of this, not just through SAGES, but through all of, and not trying to be too sappy, but through all of humanity in terms of improving medical care. And we in the military just love the civilian compatibility and working together to improve things not on the battlefield, but everywhere that needs telemedicine and telesurgical presence. Up here, sitting also here with me is Lieutenant Colonel Matt Ritter in the United States Air Force, and I would be remiss if I didn't thank him for all his contributions to us also.